Hello, everyone. Good afternoon. Thank you for joining us. We're going to start our session in a few minutes. I see a question on the chat. This is part 4. This is our final session. Thank you for joining us. Hello again, in the name of the National Latino Behavioral Association, the National Hispanic and Latino Addiction and Prevention Technology Transfer Centers, we welcome you. My name is Priscila Giamasi, and I am the project coordinator for the National Hispanic and Latino PTTC. Welcome to the final session of this 4th-part series titled Accelerating Training in Behavioral Health Equity, a learning series for trainees. I will be your host for today's session. Before we start our presentation on the next slide, we just want to share some information about our grants. You're going to receive a copy of this information and you can read at your own convenience. On the next slide, just some housekeeping items. The session is going to be recorded and archived for future playback. A copy of today's presentation will also be made available. The lines will be muted throughout the session as to minimize background noise, but we will have opportunities for you to raise your questions and participate on the session and unmute yourself. If you have questions, please share them on the chat and we will be more than happy to take these questions to our presenter. We will be also asking you to fill out a brief survey at the end of this webinar. The satisfaction evaluation is very important for the work that we do, and also provide us with the opportunity to improve our training efforts. Closed captioning is available for this event. You need to activate on your screen by clicking in the bottom of your screen, CC or live transcription button. If you have questions to activate this on your own, please let us know. A certificate of completion will be sent via email by the end of this week, and we will have some breakout rooms opportunities and more information about that will be provided soon. On this slide, we just want to take a moment and reflect on the power of words. We are all prevention leaders in our teams, communities, and our field. Together, we can use words to create positive change. On the next slide, we just want to share with you the TTC network map with information about the addiction, prevention, and mental health technology transfer centers. Each network is comprised of 10 regional centers and 3 national centers, the networking coordinating offices, the National American Indian and Alaska Native TTCs, and the National Hispanic and Latino TTCs. Our center has a national reach for Hispanic and Our center has a national reach for Hispanic and Latino communities and the workforce that provides services to these communities. Now, please allow us to introduce our parent organization on the next slide, the National Latino Behavioral Health Association, NALBA. NALBA is a nonprofit and it is located in New Mexico with the mission to influence national behavioral health policy, eliminate disparities in funding and access to services, and to improve the quality of services and treatment outcomes for Latino populations. Here are NALBA policy priorities. Select capacity expansion of mental health services for Latinos, Latino behavioral health evidence-based practices, legislation to increase the number of behavioral health professionals, funding for co-occurring disorders of alcohol and substance abuse, opioid crisis in the Latino community, and suicide prevention. On the next slide, we want to take the opportunity to invite you for the 2022 National Latino Behavioral Health Conference. Latino Behavioral Health Equity, Juntos Podemos, is happening in September 15-16 at the Sahara Hotel in Las Vegas, Nevada. This conference will provide a forum for behavioral health professionals from different areas to connect, exchange ideas, and together explore best practices to attend the Hispanic and Latino communities. I will be sharing the link so you can take a look and register to this amazing event. We are preparing incredible things for you. And our presenter today will also be a presenter on the conference, so I hope you can join us there. Here, we just want to share with you our ATTC staff. The National Hispanic and Latino HHC is staffed by Dr. Susie Villalobos. She is the project director. We also have Raquel. She's here as well today. She is the co-director. And Anna is working as the program specialist. On the next slide, you see the PTTC staff. We have Dr. Susie Villalobos one more time. She's also working as our director on the National Hispanic and Latino PTTC. I'm working as the coordinator, and I have Cristina with me today as well. My colleague, she's working as the program specialist of our center. Now I'm gonna introduce you to Dr. Sampilo, reading her bio very quickly. Dr. Sampilo is a clinical psychologist who specializes in integrated behavioral health and health disparities among diverse and marginalized populations. She received her doctorate degree in clinical child psychology from the University of Kansas, a Master of Public Health with concentration in social and behavioral aspects of public health from the University of Kansas Medical Center, and an executive certificate in social impact strategy from the University of Pennsylvania, all of which have allowed her to develop extensive experience in prevention, health promotion, and intervention for diverse populations, particularly the Hispanic and Latinx communities. Dr. Sampilo is also well-versed in public policy from her tenure as a health equity and cultural competence administrator at a state level, where she led the agency's behavioral health equity initiatives and consulted with state agencies on issues of equity and diversity, particularly related to racially and ethnically diverse immigrant and refugee populations. She's currently working as a psychologist in the Center for Pediatric Behavioral Health at the Cleveland Clinic, where she works in integrated behavioral health within primary care. She's currently serving as the health equity and social justice lead for the center, and also the chair of diversity, equity, and inclusion in the Pediatrics Institute of Cleveland Clinic. She also works with various local, state, regional, and national entities on training and professional development in the areas of health equity, diversity, and cultural proficiency. Dr. Sampilo, thank you one more time for being here, for sharing your knowledge with us. We appreciate you, and you please feel free to start your session.
Awesome. Thank you so much, Priscilla and Cristina, who's working behind the scenes today. Having a little bit of a technical difficulty on my end, so Cristina is actually going to be advancing the slides for me, which I super appreciate for this last session. And thank you all for just joining and coming along for the ride. So before I begin, I want to just sort of go through the appropriate land acknowledgement. So I'm delivering this presentation on the lands of the Erie, Kaskaskia, and Mississauga people. They were the native people who inhabited this land. We're in Cleveland, where I currently reside and where I'm currently working. And I wish to honor their enduring presence by acknowledging this history and include this history in our discussions today. I want to share a link as well to a YouTube video that's actually from several young adult Native people who are talking about racial identity as a Native or Indigenous individual. And they have certain preferences in terms of the language they use to describe their identities. And I thought it would be a really interesting watch for some of you. So again, would definitely recommend that you check out that video. Additionally, there's some other videos where other individuals from diverse racial and ethnic groups talk about their racial and ethnic identity. So there's a series. So this is one part of that series, but feel free to check out some of the other ones if you're interested. All right, next slide, please. So no conflicts to disclose for today. Next slide. And so what are we going to do today? So yesterday we focused really on education and self-reflection. So really thinking about sort of our positionality, sort of our social location when it comes to this work. You really can't promote social justice without understanding where you've kind of fit in the milieu or the social ecology of things. And so we're going to move on to the next step. This is a beginning learning series. And so the idea is to try and promote a little bit of that self-reflection and then get you thinking about some strategies or some ways to really promote social justice. And that really begins with centering the voices of marginalized or minoritized communities. So we're going to talk a little bit about centering those voices in these 4 areas today: in clinical practice, in community engagement, in research, and in policy. I know we have a range of trainees at different levels of training currently participating in this training. So I want to talk about some of the key areas of like graduate training or master's or doctoral preparation. And so these are some of the areas that mostly jump out. Next slide, please. So at the end of the day, what I want you to understand is social justice is a goal, but it's also a process. So the end goal, right, is justice, liberation. We want to promote social justice sort of as one of those end goals. If we think back to those panels, it's sort of liberation, no fence, no need for the fence, no barriers, no need for the support boxes or what have you, because we have broken down the structural or systemic barriers that disadvantage some, right? And so it's the goal, but there's a process to get there. And social justice is also that, represents also that process. Next slide. So where does that really begin? And again, beginner learning series, so we're really going to start at the beginning. And now we're going to sort of move from the internal, which was yesterday, to now, how do we start to really promote and really adopt this work externally. And again, that's going to really focus on centering the voices of the marginalized individuals and changing practices and processes to really center their voices, because this won't be necessarily a passive process. Changing these processes to center their voices is not something that we historically have done in the behavioral health system. So it is going to be, or will require an active process, an intentional process in terms of doing that. Next slide. So I know that all of you are likely familiar with cultural humility in one way or another. So I'm not going to spend a ton of time on cultural humility, but I do want to sort of give that as the background because it does sort of lay the foundation or parts of the foundation for our discussion today. So what is cultural humility? So if you think about cultural humility, I'm sure a lot of you know the term or the broad umbrella term of cultural competency. Cultural competency used to be sort of what we work towards, sort of thinking about like end goal. People used to think it was cultural competency. Now we sort of realize that that really is a bit of a misnomer, right? Because we're never truly going to be competent in any culture besides our own individual cultures, right? So for example, yes, I am here today leading this discussion. I work a lot with our Hispanic and Latinx populations, as well as our Asian populations. I am not necessarily an expert on those populations outside of my academic and book learning and experience, but I'm not an expert on them the way I'm an expert on my own cultural background, right? And so I can aim to work very effectively with them while also understanding there's still a ton that I need to learn, a ton that I need to grow from in that space. And so that's really why cultural competency became a sort of a misnomer. It's still sort of the broad term that we use in terms of federal language, right? We're working towards cultural linguistic competency, but generally the idea is also understanding that we're never truly going to be competent, but what we can become is more proficient. So cultural proficiency is sort of really, if you think about the cultural competency spectrum, cultural proficiency is more of sort of the end of that spectrum. But what is required to work more proficiently and effectively with communities is cultural humility. And so that's sort of this foundational concept. And what really is going to be required if we think about long-term for social justice, it's really going to require a combination of cultural humility and also sort of structural competence. And structural competence sort of beyond the scope of this training series is kind of more for the advanced training series, but it is something that we need to work towards as well. But cultural humility, again, sort of outlines that commitment to self-evaluation and self-critique. So frankly, we did a little bit of that yesterday. And so the idea is it really focuses more on you as an individual and you as the leader of your own processes in terms of that self-reflection. And the definition or sort of the definition that the authors or sort of the individuals who came up with this concept, if you will, they sort of termed it as incorporating a lifelong commitment to self-evaluation and self-critique, to addressing the power imbalances in the patient-physician dynamic, and to developing mutual beneficial and non-paternalistic clinical and advocacy partnerships with communities on behalf of individuals and defined populations. So Dr. Turvalon and Dr. Murray Garcia, established this framework or established this construct as a way for us to really put words to the position or sort of the perspective that we need to adopt in order to work effectively with other individuals who may not be very similar to us or who may even be similar to us, but in terms of sort of always being in that spirit of sort of learning and growing and committing to always reflecting on sort of what we're bringing to the table as well in those interactions. Next slide, please. So when we think about cultural humility, it really is focused on individuals. So again, if we think about cultural competency historically, how that's been utilized or historically how that's been used, it used to be more focused on sort of racial, ethnic diverse groups. That's really what cultural competency focused on. Cultural humility is really sort of more focused on individuals and really giving more focused attention to other aspects of culture, including gender, geographic location, country of origin, sexual orientation. And again, don't walk away thinking cultural competency is a bad thing. It's definitely not a bad thing. It's definitely something we still want to promote. It's just cultural humility is sort of a step and a necessary step in order to be more proficient and effective in working across cultures. Cultural humility really also promotes this sort of continuous ongoing process. Again, it's that idea that you're never going to be truly an expert on any other culture besides your own individual culture. And by doing that, you're sort of committing to lifelong learning, meaning you're always going to be meeting folks that are new, coming across or experiencing cultures that are not familiar to you. And so as a result, you're sort of always in that spirit of learning. And it's more focused on achieving flexibility and humility rather than on competence. And that's, again, one of the differences between cultural humility and cultural competence. Next slide, please. So at the end of the day, if you want to put like cultural humility, sum it up in a nutshell, this is sort of the quote that kind of captures, I think, cultural humility. To be culturally humble means that I'm willing to learn. That at the end of the day, no matter how much learning we do, no matter how much training we do, including myself, is that I will never truly be an expert on any one individual besides myself. And as a result of that, I'm always in that spirit of trying to learn, whether it's learning about an individual or learning about a culture or learning about a community or learning about perspective that is different from my own. I'm trying to be in that space where I'm willing to learn and I'm open to learn, and I'm taking off sort of that expert hat. Next slide. And so why do we focus on cultural humility? Because at the end of the day, we only see about like 10% of anyone's culture. We only know the surface characteristics, right? So based on maybe what you see, based on what you hear, based on your initial introductions to individuals, you might get maybe roughly, that surface level of their culture. But really what makes up culture, what is the foundation for culture, all of the things that we think about when we think about more deep structure, the things that lie below the surface, right? Your attitudes, your beliefs, the systems, your formative factors, the things that are not necessarily observable, right? We can't necessarily see your values, beliefs, cultural practices, cultural processes, cultural traditions. We can't see all of those things, right? They're not necessarily readily observable to, the outside eye. And so really thinking about how we don't really know truly about someone else's culture without really digging into that deeper structure. We only really see the surface. And so that's why we really need to practice cultural humility, because we only know a little bit based on what is observable. Next slide. So when we think about cultural humility, we also want to think about how we sort of maybe adopt that or sort of utilize that in these different processes within behavioral health. Obviously, this is not an exhaustive list. I'm just thinking about sort of where trainees are in their behavioral health sort of journey in terms of their training and their education right now. And so these are some of the areas that are going to be central to the things that you learn, the things that you train on as you move forward in your different careers. So we're going to talk a little bit about ways to demonstrate or sort of take a culturally humble perspective to doing clinical work, to engaging with communities, to doing research, and then to also engaging in advocacy. Next slide. So when we think about, again, sort of social justice as a process, part of that is infusing our clinical practice with cultural humility. And one of the ways that we have to do this, we have to center communities' voices in our clinical practice. And so you want to think about, okay, am I centering minoritized or marginalized voices in my assessment, in my treatment planning, in my progress monitoring, and in my termination planning? So for those of you who were present on session 1, we actually talked a little bit about behavioral healthcare disparities, right? So differences in access, differences in quality of care, differences in actual practice and standards of care that can sometimes be seen between marginalized communities, right, compared to majority communities. And so part of that is not necessarily taking into account or centering the community member's voice in that work. And if we did, then maybe we wouldn't see as many of those behavioral healthcare disparities. And so really we want to think about how or what's a way that we can center the voices of marginalized communities in our clinical practice. So next slide. So one of the ways that we can do that, there's actually a tool available that can be really helpful for this purpose. The cultural formulation interview, which was developed by the DSM-5 cross-cultural issues subgroup, and they have field tested it with providers who have documented its usefulness. They've also field tested it with patients to document its acceptability among patients. But basically, it was a response to really that understanding of an individual's racial, ethnic, and cultural identity is a source of strength. It is an asset that individuals bring to the table. And that should be something that we center, frankly, our clinical practice around. And in addition to that, an individual's racial, cultural, ethnic identity, and all of the different aspects of their diverse identity is important to this sort of how they navigate the world and how the world, how they perceive the world and how the world frankly perceives them or how they're treated. And so really, we can't really separate out those identities from the clinical process. And so the formulation interview was sort of developed, or the CFI is sort of how it's termed, was developed to be able to take that into account. And so it's really designed to facilitate and improve cultural assessment and then cultural case formulation when you're talking about patients. Next slide. So when we think about the cultural formulation interview, it's basically a part of an assessment process, if you will. And different individuals use this differently. So I've seen some people adopt the CFI as their standard intake interview, like completely from start to finish. I've seen people incorporate components of it in the ER in terms of their intakes and things like that. So there's a lot of ways people have used it. It is designed as a full interview, and there's different modules for like using the interview with like adolescents or like older adults and different subgroups. But at its core, it's a really useful tool to get at ways to ask questions that center the voices and perspectives of the individuals that you're working with. So we're just going to go through a few sample questions and just sort of go through the different components or sort of domains that the cultural formulation interview sort of covers. So it really starts with figuring out a cultural definition of the problem. And so really what this question or the series of questions under that area, the cultural definition, really is looking at an individual's perception or definition of core problems and key concerns, how their individual's description of the problem to their social network, so how it would be perceived within the folks closest to them, how folks closest to them might perceive that problem, and then their beliefs, thoughts that are most concerning about aspects of the problem. And you can see how this could immediately be useful, right? So if you think about patients who maybe, and I know I've had this experience where I've had patients, families come into my office and they don't know why they're there to see me for whatever reason. It might have been a recommendation from the doctor, but maybe that reason for referral wasn't as clear. And so they show up in my office and they really don't know why they're there, or they have different definitions or perspectives on why they're there. So this really allows them to really help define what they perceive as being the definition of their particular problem. So one of the sample questions on the CFI to kind of cover this domain is, what brings you here today? People often understand their problems in their own way, which may be similar to or different from how doctors describe the problem. How would you describe your problem, right? And again, just thinking about the folks that you work with, sometimes we operate under the assumption of the referral issue is this. So we're assuming that this is what they perceive the problem to be as well. And that may not actually be the case, right? So this allows you to center the voice of your patient, really. Next slide. So the next domain covered within the CFI is the cultural perception of the causes, context, and support. So some of the aspects it's attempting to get at it are things like beliefs and thoughts about causes of their problem, causes according to their social network, again, those closest to them, how the environment is supportive, and how the environment is stressful. So you're looking at a couple of different things, right? You're looking at environmental stressors, social, ecological, maybe stressors, social ecological impacts. And then you're also looking at their beliefs about the root causes of their problem. And not only their beliefs, but the beliefs and maybe thoughts of others who are close to them, right? Because that may give you some additional information. So the question, one of the sample questions in this domain is, why do you think this is happening to you, right? So again, giving them the opportunity to more broadly describe and capture what cultural factors may also emerge from that question. Next slide. Again, what we know, and one of the reasons that the CFI was created was to really acknowledge and really embrace the idea that the role of cultural identity is so central to clinical practices and processes. So in the domain of cultural identity, the questions are meant to get at key aspects of your background or identity. So, again, what maybe aspects are most important to you, the impact of key aspects on the problem, and other concerns related to key aspects of their identity. So the sample question is, for you, what are the most important aspects of your background or identity? So imagine yourself sort of, being asked that question and thinking about a problem that you might be experiencing. If you think about it from that lens with this question, for you, what are the most important aspects of your background or identity? That question alone gives you an opportunity and an entryway to learn more. And again, if you're the one receiving the question, express more about maybe what are the things that are central to you in terms of your identity, similar to what we did yesterday. And part of that is also not just acknowledging and understanding that, but also understanding how that might be a source of strength, how that might be something to leverage in terms of their treatment planning, and then also helps maybe frame the problem more from their lens of understanding and perspective, right? So really understanding aspects of your identity. And we know that that's really critical and central to treatment and treatment planning and treatment success, frankly, and treatment retention, honestly. And so it's really, this is one question that can be really helpful in terms of ensuring that your practices and processes are more respectful and more integrative of those different aspects that are important to that individual, that are salient to that individual. Next slide. So another domain is cultural factors affecting self-coping and past help-seeking. So we know that there are a lot of cultural influences on help-seeking behavior and or how folks sort of perceive help-seeking. So this domain will get at areas such as methods of self-coping. So what have you used in the past? What do you currently use? Past help-seeking, and then barriers to help-seeking. So again, a sample question from this area of the interview is sometimes people have various ways of dealing with problems. What have you done on your own to cope with your problem? And that really, again, is a very broad way to ask what have been your attempts in the past to cope with this problem. And again, part of that is maybe to pull in other ideas or other strategies or other tools, other cultural resources that they've utilized in terms of coping with problems, including things like traditional medicine. And it's also asking that in a way that's non-judgmental, right? We're not passing judgment on whether or not you've elected to use, I think traditional medicine, which I think historically has not necessarily been viewed always as positively, but certainly is a positive and is a strength for a lot of cultures. So being able to use that, right? So if someone were to ask me that question, and frame it that way, I would say that that probably is something where that question would elicit a response from me that wouldn't necessarily elicit in a more like, what coping strategies have you tried before? Because I wouldn't necessarily, for whatever reason, it wouldn't necessarily constitute in my brain that what I used to use, or not sorry, what I used to use, I still use it. What I still do now, which is where I go to my aunt and she passes the egg and she takes away all of the evil spirits and I feel fine. That isn't necessarily used in terms of like, how I connect that in coping strategy, right? That is a traditional practice that my family uses. It's a traditional practice that I use. And again, I think it's non-traditional in that way, but for me, it's a very strong part of what we use to cope in our family in terms of stress or in terms of what we perceive as being bad things that happen, right? That is something that I would mention if the question were asked this way to me. But if someone were to ask me like, what coping strategies do you typically use? My like mental health psychological brain might say, deep breathing, things like that, things we traditionally think of in mental health practice and not necessarily these cultural traditions that my family has. So again, just sort of thinking about how this can elicit response. And so I don't know if for folks on the call, it's called passing the egg. It's a traditional practice, at least for my family, it's from the mountains of Peru. Next slide, please. All right, so another domain covered by the CFI is cultural factors affecting current help seeking. So areas that this area is intending to get at are the perception of what would be most helpful and beliefs, thoughts about other kinds of help that would be helpful. So are there other kinds of help that your family, friends, or other people have suggested would be helpful for you now? So not even just looking at what that individual thinks, but are there other aspects of help or support that family, friends, or other people might have suggested or might think would be helpful for you? So again, getting at maybe some other influences on help, other possibilities and other influences on help seeking. Next slide. All right, and then also in this area is looking at the clinician-patient relationship and particularly important misunderstandings that maybe have happened in the past that you should be cognizant of in your work with an individual that could impact their behavioral health care experience and their behavioral health care engagement, and then how to provide care. So sample question in this area is sometimes doctors and patients misunderstand each other because they come from different backgrounds or have different expectations. Have you been concerned about this? And is there anything that we can do to provide you with the care that you need? So in this question, we're being a lot more proactive about asking, have there been experiences in the past? And again, for a lot of our marginalized communities, they have a distrust of the medical system due to historical bias and racism within the medical system. So they may have some previously negative and or aversive experiences within the healthcare system. And so knowing those things and then asking, is there anything we can do to provide you with the care that you need or want, I think, again, shows and demonstrates that we're acknowledging that possibility and that history. And we're also giving you an opportunity to tell us how we can maybe address that proactively. Next slide. So I just wanted to give a brief overview of the CFI. The CFI, obviously, way beyond just understanding the CFI, way beyond the scope of this learning series, but I wanted folks to just be aware that the tool actually exists in case you were not familiar with the tool or haven't heard about the tool. This is not something I learned necessarily in my graduate training. I went to graduate training a while ago, but I don't know if this is traditionally in current graduate training programs, but it is an important tool that I think would be great for folks to be able to access and utilize or incorporate into their practice, again, feeling that they're comfortable with it, they've trained on it a little bit and feel like they have that competence to use it. But I do think it's important. And I will say from my own personal experience and practice, I do incorporate aspects of the CFI into my consultations and my assessments. So I do integrated primary care, which means I do sort of warm handoffs, which is a primary care or a physician has someone who presents to the office with a behavioral health concern. They pull me in and then I do a consult. I do actually use some of these questions in my consult, and I have found them to elicit more different responses than when I traditionally have used my more standard interview. And so it can be very useful, and I think it does glean some very unique information, and I think is really responsive to, again, that idea that individuals' identities and their various diverse backgrounds is something important to consider and something important to try and elicit in that clinical practice process. Again, it's sort of one way of centering their voices, if you will, and centering those identities in certain ways, if you will. So this is just some information on how to access the CFI. Again, it's certainly beyond the scope of this training series, but I hope this is just at least a little bit of an introduction into what a culturally centered and sort of community or community-centered approach, if you will, to doing a clinical assessment looks like. Next slide. So that's part of the clinical practice. Remember, we're going to talk about 4 different areas. The next area I want to talk about is community engagement. So thinking about how do we even engage with communities? We don't see things as they are. We see things as we are. I really like this quote because I think it really says a little bit about we bring a perspective, right, to things. So we don't see things as they actually and truly are. We see things as we are, right? It's our perspective that sort of colors a little bit of how we see things. And so part of working with communities is really trying to understand communities from their perspective, which again, when you go into a community, you don't necessarily see them as they are. You see them as you are, or as we are. Next slide. So when I think about community engagement, and I think about centering their voices and, practicing and promoting social justice in this work, part of what you want to consider is your space when entering a community. And what I mean by space, I mean your positionality, your perspective, your biases, your lenses that you're coming into that space with. So I want you to consider your space when entering a community, your knowledge about the community or communities. So what you know about this community, what have you sought, what information have you sought, what education have you sought out, what experiences have you sought out to know a little bit more about this community. Again, you're never going to be an expert on them, but it's important to sort of determine or at least assess what your current level of knowledge about a certain community is. And then how do you then build trust with the community? I think historically, there hasn't been a lot of emphasis, as much emphasis as there should have been, at least in clinical psychology. In other domains, I think there has been, but really a lot more attention recently on how do you even enter communities? How do you build trust with communities? Because I think historically in clinical psychology, it's been a little bit of that white ivory tower perspective where individuals in professional positions or individuals within like academic medical health centers or universities have a certain level of expertise that they then bring into the community and then help the community. And that's not really how it should be done. It should be more of a collaborative partnership where the community are sort of leads and centered within this work. And so we didn't really think about these things as actively as an intention and intentionally as we really should have. How do you build trust with the community? How do you increase your knowledge and increase your education about a certain community? And these are really important things to thinking about. How do you work effectively with communities? Next slide, please. So I really like this approach by Satterwhite and colleagues. And so this is actually an approach that they've adopted for culturally based capacity building with communities. And so it's more focused on capacity building, but I do think the primary tenets are also really helpful just in terms of thinking about how you work with communities. So really they lay out these like 5 big tenets, and I think they're really useful to keep in mind when doing community engagement, community outreach, community programming with those communities. Is you really work from the community by listening and learning. And that's the very first thing. And so you notice it's not necessarily focused on the information we bring or what do we offer or what do we give them. It's focused on really listening and learning to the communities themselves. And you work with the community by co-designing the training strategy. So whether it's, you're going in with an idea about a program that you think could be beneficial, that they perceive a need for, that you maybe have the resources and you're going to partner potentially on this program, you want to actually do that by co-designing the change strategy. So whatever purpose or goal you have in working with a community, if there is like an overarching purpose and goal in terms of program development or something to that effect, you want to co-design the change strategy with that community, right? You don't want to develop a strategy and then implement it. It's about co-designing that. And you work in the community by facilitating action and learning. Again, sort of prioritizing learning and sort of that humble or that humility, that humble approach or that humility really in terms of facilitating action and learning. You work for the community to build capacity for social transformation. Again, thinking about if you're doing program development or engagement in some way with a community, you're really trying to also build capacity for social or sort of broad scale transformation within that community. And you work for the community by building towards collective impact. Collective impact is sort of like a public health approach, again, beyond the scope of this presentation, a little bit more for like advanced trainees, but collective impact really is about cross-sector, multi-sector, cross-sector collaborations to really work on solving complex social problems. And collective impact is an approach that does that and can effectively do that in a lot of ways. But you want to sort of think about, how do you build towards that collective impact? Broadly or longer term. All right, so that's a little bit about just thinking when we engage with communities, how do we do that with sort of a social justice lens? Again, it's about centering the voices of the community, and you notice that all of these tenets really do center the community rather than center the individual or the academic or agency or organizational partner. It's really centering the community itself. So that's a little bit about some considerations for community engagement. Part of community engagement or community like program development, sometimes research is born from that. So now we're going to talk a little bit about research and how do you center communities in research. Next slide. So one way to center communities in research is really to focus on community-based participatory research, or what's also known as community-based participatory action research. But one of the primary goals of CBPR is to achieve social justice through social action and social change. And so one of its goals in and of itself is social justice. So again, thinking about back to that first slide of social justice is not just a goal, but it's also a process. This is a process where social justice is really centered in it. Next slide. So some of the key principles of community-based participatory research are, we're just going to go through some of these principles one by one, just so that we can be aware of some of the different ways that community-based participatory research differs or is different from some of our traditional other research methods. So one is that it recognizes the community as an important identity. So from the outset, from the jump, you are respecting and sort of acknowledging that the community itself is an important, invaluable, and irreplaceable identity that you need to sort of understand and work with, right? So it really just sets that as a standard from the beginning. And it builds on strengths and resources within the community. So it's really sort of a strength-based approach, right? Recognizing and understanding what are the assets, what are the strengths of those communities, and then building on those strengths and resources within the community. Next slide, please. It facilitates collaborative and equitable involvement of all partners in all phases of the research. So this is critical. So I'm going to spend a little bit of time just on this point. One of the things of CBPR, one of the advantages of CBPR is, or one of the strengths of it is, really focusing on community involvement throughout all phases of the research. So from problem identification to, planning to, design to implementation to evaluation, it's really prioritizing the community and having them centered throughout all phases of the research plan. And the reason that that's really important is sometimes that's not necessarily the case with other research methodologies. This is a primary tenet of CBPR, so it's really part and parcel of how you conduct this research. Whereas with other research methodologies, it's not as clear or intentional that you're really involving community partners or community stakeholders in all phases of the research. And I will just tell you from my, just conversations and my work with communities, one of the things I hear a lot are their frustrations with individuals who don't necessarily involve the community in all phases, right? Maybe they're involved in certain phases, or maybe they're involved too late in the process, right? The idea, the program, it's already been designed and sort of offered to them as this could be helpful, whereas the community, hasn't really had input into that. Or in terms of the evaluation, I've also heard from communities feedback is that, the evaluation, the results, the team must have come up with the results, but they didn't really share the results with us. There wasn't like a formal sharing of the results from the evaluation with the communities. So, they didn't really close that circle or close that loop. And one of the other things that I sometimes hear from communities is also feeling like they aren't, they're not necessarily a part of all phases of the process, but they're also not receiving communication throughout phases of the process. So also being more transparent and open with communication about these efforts is really important to communities. So the fourth, one of the fourth principles is integrating knowledge and action for the mutual benefit of all partners. So again, part of that is, again, from the very beginning, working with community and centering their voice about what would they hope to be the benefit of this effort, right? Because everyone comes in with like some agenda in terms of what their goals are, what the responsibilities are, what they're accountable to in terms of who you are and where you work. But you have to figure out, how do you create a program? How do you create a project that is designed for the mutual benefit of all partners involved? Next slide, please. So community-based participatory research, or CBPR, also promotes co-learning and empowering process that attends to social inequalities. So really, it's about also empowering communities, right? And doing that, again, in a collaborative way. And it promotes co-learning in that way too. So it's not just about, obviously, integrating and working together, but you're also learning from each other throughout that process. And you're attending to social inequalities, because by working with communities, you become more knowledgeable and aware of some of the different social inequalities or the different social ecological factors that drive some of the inequalities, some of those structural drivers as well. And so you're sort of doing work in that space while working, obviously, collaboratively with the community. CBPR also involves a cyclical and iterative process. So one of the things that's really critical to CBPR is, unlike other research methodologies where you implement a program from start to finish as designed as is, if in the course of your project you realize, hey, this strategies or the project is not working as intended, unlike other approaches where you might have to move completely from start to finish with that project and with that project as is, and you can't necessarily make changes depending on the approach. In CBPR, not making changes would be irresponsible. So you have to respond to the needs of the community, and something's not working. We have to sort of iterate, right? We have to sort of implement things that are responsive to the needs of the community. And so it's a little bit different in that way. It also just involves more of a cyclical and iterative process, because you have partners in the community that you're working really closely with, right? And so as you get feedback, as things sort of evolve within all of those partnerships, you might do more of a cyclical iterative process of, designing strategies, implementation, and evaluation, right? Like this is an ongoing thing that we're going to be committed to. Next slide. And it focuses on health from both positive and ecological perspectives. Again, it's very much a strength-based approach. You're looking at the assets of a community, and you're also focusing on health from both a positive and that ecological perspective, right? So we're not seeing a community in isolation. We're seeing a community within its social and ecological context. And so you're focusing on health from that perspective as well. And it disseminates knowledge gained to all partners. Again, that goes back to one of those other principles I mentioned about sort of the communication, the transparent communication and ongoing communication, sort of a structured feedback loop that you sort of have with communities when you're doing CBPR or engaged in CBPR. Next slide. And then also promotes a co-learning, empowering process, and then attends to social inequalities and health disparities. I apologize, that's a bit of it's a repeat of an earlier one, but it attends to social inequalities and health disparities. So it's really focused on and intentionally focusing on trying to address those social inequalities and health disparities that community may be experiencing or may be subjected to. And again, it's thinking about it from the lens of, it's not the community itself that needs change. It's about the things that structure the environment around the community that likely need to be changed or likely need to be addressed in some way to help the community, again, be as healthy as possible. All right, next slide. Okay, so that's a little bit about CBPR. And again, part of why I wanted to highlight CBPR is it's not necessarily an approach to research that was covered a lot necessarily in my graduate training. There was some, I got an introduction to it and things like that. But it really is one of the approaches that research approaches that really centers communities and the voices of those communities within that research process. And so as we think about social justice, again, not just as a goal, but also as a process, how can we integrate the voices of those communities into some of our practices, and sort of considering other methodologies or considering other ways to work with communities might be something to pursue. So now we're going to sort of move to forms of advocacy. And again, I know that I'm going through all of these things fairly quickly. And part of that is just to sort of give you an introduction to some of these things, because this is a beginning learning series. But I feel like as long as I can give you a bit of an introduction, it allows you all to, do additional research, look into some of these things even more. If you're interested in CBPR, interested in, community engagement work, or interested in the CFI, it gives you sort of something to kind of explore maybe potentially on how you can incorporate some of these things into your behavioral health practice. So we're going to talk about advocacy. So traditionally, advocacy hasn't been seen as a responsibility or a job necessarily, or one of the domains that psychologists or behavioral health professionals engage in. I will exclude social workers because I think for a lot of history, social work really has been oriented towards advocacy. But I would say more so in terms of like clinical psychology, those areas, advocacy really hasn't been a core component of our practice, if you will, or sort of our professional domain. That is changing. And part of the reason that is changing is because we recognize that as individuals who work in behavioral health, we have to advocate on behalf of our patients, particularly our patients who are underrepresented, underserved, marginalized, minoritized in various ways, because we can't close the gap for behavioral health disparities. We can't promote equity without advocating for change for those patients and for those communities. And so for those of you who are, training maybe in clinical psychology, counseling psychology, school psychology, what have you, you might be familiar with that concept of a citizen psychologist, which is a psychologist who really responds to, frankly, civic needs, right? So advocacy is a core component of civic need. And so really starting to have trainees start to develop a lens of advocacy or develop some knowledge of how to engage in advocacy can be important. So we're going to talk a little bit about advocacy now. And there's really three forms of advocacy. There's self-advocacy, individual advocacy, and then systems level advocacy. And I'll sort of explain each one right now. So self-advocacy is really advocating for yourself. But part of, and that's sort of like self-explanatory, but part of self-advocacy is also really trying to help others be informed of, practices, procedures, guidelines, things that also would help them advocate for themselves, right? So if you're familiar with certain processes or guidelines or rules that would allow someone to, if they were familiar with those same things, to advocate for themselves, if they would know some of that information, it's important to help share that information. So whether that's with patients, right? So if a patient, for example, comes into my office and tells me that they had a negative experience with some other provider or a negative healthcare experience in general, I would let them know and I would help them understand sort of our ombudsperson process, right? To allow them to know that they have this form to be able to share their concerns or share their experience with, someone within our institution that could potentially address that concern, right? If there's issues with like billing and reimbursement, I try my best to provide the information I can and then connect my patients to the appropriate office within our institution if there's some issue there, right? So self-advocacy is obviously advocating for yourself as an individual, but it's also about providing information or providing knowledge to individuals so that they can also more effectively advocate for themselves as well. Maybe that's help navigating the system. Maybe that's like, again, just letting them know there's this process that exists, but giving them information so that they can also advocate for themselves more effectively. Individual advocacy is basically advocacy done on behalf of an individual or on behalf of a group of individuals. So you as an individual are advocating for another individual. So you're taking more active advocacy process in that way. So you're advocating on behalf of this individual, or you're advocating on behalf of this group of individuals. So that's more of an individual advocacy. So as an example, if I have a colleague in my department and they've perceived an issue, and now I'm going to our chief or I'm going to our diversity committee and I'm saying, this is a concern that's been brought. I want to make sure that we're addressing that. That is individual advocacy, right? There's an identified individual with an identified need, and I'm now advocating on their behalf. It's different from self-advocacy where I'm advocating for myself or just giving someone information, right? I'm now actively engaged in a process to advocate on their behalf, whether that's an individual or a group of individuals, right? And you may do this as an individual, or you may do this, again, sort of on behalf of individuals. So a group that you work with may express some concern, may express a desire for an issue to be brought up to your institution or your agency, and you then share that information with your agency. You are now advocating on behalf of those individuals. Systems level advocacy is more about advocating for changes in system processes, so policies, procedures, practices that would facilitate more of a systemic change or some sort of transformative change within an institution or agency. So this is sort of like thinking if, for example, one of the things that came up at Cleveland Clinic recently was that there were looking at different holidays and sort of not having as diverse of a holiday calendar as we would like to have. And so raising that issue, not necessarily on behalf of any individual or any group specifically, but sort of saying broadly, we want to diversify our holiday calendar, right? And be more inclusive with that holiday calendar. That is a systems level advocacy sort of approach, right? You're advocating for a change in that system. If one of the things that we're looking at doing differently is our recruitment and our retention processes for our staff and faculty here. And that is advocating for a systems level change, right? Again, it's not on behalf of any individual or any group of individuals, but it's saying we're looking at our processes. We don't think our processes are sufficient as they stand in terms of ensuring that we are being more intentional about diversity in our recruitment and retention. And so now we want to change or alter our processes. That's a systems level advocacy sort of thing. If you get, emails about, hey, comment on this open call about, guidelines, or on this open call about reimbursement, again, that's systems level advocacy, right? You're attempting to change a process or policy or procedure that potentially has impact on individuals. And I apologize. I've been meaning to monitor the chat and I just have not done effectively a job of that. So I'm going to just quickly look at the chat. And I appreciate, Andy, your question may have been related to like the CFI that came out around in like 2013. So there were some initial discussions in like 2013 with DSM-4 actually, with sort of an outline of thinking about culture, right? And then sort of what led to the CFI was that initial sort of discussion in DSM-4, the revised version, and then DSM-5 had the actual CFI in and of itself. So definitely it's something, worth checking out, worth, considering. And again, just, as an FYI, some folks, have not heard of it before. And so have said, has it been used? It has been utilized in a lot of different arenas and ways. They did, field testing to demonstrate its usefulness for providers and its acceptability to patients. So it's been vetted, and there's some research. There's a research literature on its use too. So definitely feel free to check out cultural formulation interview in your local journal search engine, and you'll pull up some of the literature around it. All right. regarding advocacy, the last point that I want to make particularly to this slide is that advocacy can be formal or informal, right? And so informal advocacy can be things such as, on your own time, responding to email calls to, advocate in some way and comment on, certain documents that maybe come out, like federal guidelines and things that we often will sometimes get in our emails. Or it can be more formal. It can be as formal as, so for my residents or residents interns who work with me at Cleveland Clinic, we try and make their advocacy a little bit more, to give them a little bit more experience with formal advocacy. We have them write written testimony. They don't have to submit it if they don't want to, but they can submit written testimony on any particular bill or issue that's gone to committee, essentially. And so our last cohort of residents, they drafted written testimony, submitted to me. I gave them feedback, and then they had the choice of submitting that more formally. They also get the opportunity to participate in like legislative day, where we go down to the state capitol and potentially set up meetings with actual legislators. Due to the pandemic, it's just been hard to set that up, but we're hopeful that we'll be able to do that this year. But there's different opportunities where you can do more formal advocacy, but you can also do informal advocacy, and you certainly can do that as your own private citizen. I think it's important to note, obviously, as a lot of the folks on this call are trainees, it's important to understand when you also are engage in advocacy, whether you're representing yourself or whether you're representing your institution in any kind of way. And that's a delicate balance that you want to make sure that you sort of denote or delineate what you're attempting to do and who, again, you're representing. Because there are a lot of things I can do as an individual on an advocacy level. And there are certain things or certain ways I have to do advocacy if I'm representing Cleveland Clinic, right? So I just want to make sure that trainees understand that there is a distinction there, and to always just sort of be mindful of that in terms of your role. So for example, when I'm advocating formally, I may use my letterhead if it's a formal form of advocacy that's been approved by my institution to engage in, right? But if we have a whole office of like government affairs here, so there's like a whole process that we can go through. But if I was just, responding to something as a private citizen, I would not necessarily use letterhead, or not necessarily, I would not use letterhead because it's me as a private citizen, but I also may not necessarily reference my role here at Cleveland Clinic, my professional expertise, my professional job, yes, but it may not affiliate myself with Cleveland Clinic in that way. So I think, again, it's just important to understand and delineate that, especially for trainees who might be new to thinking about advocacy and how to engage. All right, next slide, please. So, we actually did all of this. Sorry, I had slides on this. Engaging in advocacy on yourself is, again, understanding and asserting your own rights, speaking up for yourself. And as a clinician, supervisor, mentor, trainee, person who's providing services, you can inform and encourage one's understanding, as I mentioned. So just about sharing information. Next slide. We'll go through these pretty quickly. Advocacy efforts are concentrated on the individual or group of individuals, like I talked about, and you may advocate for a vulnerable individual or for a group of vulnerable individuals, like I just mentioned. I did not mention this. Advocacy is done by a single individual or by a single entity. So you as an organization can also engage in individual advocacy, sort of a misnomer because you're an organization, but you're engaging on behalf, or you're advocating on behalf of an individual or a group of individuals. And so that would still be considered individual advocacy. Next slide. And then systems, we sort of this talked about that, developing policies or advocating for developing policies or changing policies that will generally result in some sort of positive benefit, not only for patients, but for the organization or agency itself. And it can involve issue-based advocacy and or partnering with issue-based advocacy organizations. And as I mentioned, advocacy can be formal or informal. The other thing that I haven't mentioned is you can advocate pretty much anywhere. So I don't want folks to think like advocacy only is when you go to the state legislator or you go to your local school board. That would be a great way to advocate as well, as to, attend local school board meetings and things like that. But one of the things I want also folks to understand is you can advocate very locally, meaning within your own agency, within your own department, within your own graduate school program. You can advocate for certain things that you feel would be beneficial for either, again, your colleagues, your peers, other individuals, your patients. You can advocate for something that benefits them. And you can do that, again, as locally as within your own sort of day-to-day functioning. So as an example, I advocated for a diversity committee here. I got it, and I got the ability to do that, but that's something I had to advocate for. I advocated for that at a previous institution where I worked. They didn't have one, or they did have one, and then it disintegrated, and so we had to restart it. So I advocated for that. You can do that in graduate training. Are there things that you'd like to advocate for? For example, we talked about the CFI. That may be something you want to receive more training on within your grad program. So maybe you advocate for bringing in a speaker who can teach or train a little bit on the CFI, right? That's advocacy. If it's going to benefit individuals, particularly individuals from marginalized communities, and you're trying to bring something or bring awareness to an issue or bring resources that will help benefit them. That is advocacy. Advocacy doesn't have to be what you typically think of when you see like actual legislative advocacy. It can be locally. It can be you voting. That's a form of advocacy. But I want people to understand advocacy can take a lot of different forms, including forms that are more local to you. All right, next slide. So when we think about advocacy, I want us to think about sort of advocacy action planning, which again, I'm doing a lot of that. Mostly the slides are for the trainees, right? Because you might be thinking like, well, how do I even start in terms of advocacy? Like, how can I become more of an advocate? One of the ways is to think about it as, again, sort of like a goal or a strategy. So what you might think to yourself are, what are my goals, right? There's an issue that has arisen to your awareness. That's something that you feel passionate about. And you want to do something about it, but you're not sure how. One of the things you can do is sort of ask yourself, like, what could be my goals in this space? What do I want to see improve or change, short-term, intermediate term, or long-term, right? Who will my goal impact? What specific population are you aiming to impact? And whose voices are you centering in that? Again, trying to always remember keeping voices at the center. And who is in my intended audience? If I am advocating, who am I intending to receive this message? Because who is your intended audience may alter or may influence how you want to deliver your messaging, or who even is delivering your messaging. Sometimes even, like, for example, I'll be really honest, sometimes there are times where in my past where I've had an issue that I've noticed and I've wanted brought up at like a faculty meeting or what have you. And I don't necessarily think I'm the best deliverer of the message, because it's always sometimes me, right? And so I might say to my peer, hey, I feel like if I bring this issue up, it's just going to be me, I might be perceived as just bringing up issues of diversity like over and over again. So I actually think it would be helpful if you would actually bring this up, and I will back you up. And I've done that because I sometimes recognize that I may not always be the best deliverer of the message, depending on the audience, depending on the context. And that's sometimes hard to swallow, right? Because it doesn't necessarily seem fair. But at the same time, I want the most effective message for advocacy, right? So thinking about who your intended audience is may impact, again, or may influence the way you deliver your message, and frankly, who even delivers your message. Next slide. And this was sort of that point. What is the best way to deliver the message, and who's the best deliverer of said message? And then thinking about what assets do I have? What resources do I need to engage in this advocacy, right? So again, thinking about distinguishing your professional role versus your non-professional role, or your private citizen role, maybe that comes here in terms of what assets do I have? So as a private citizen, what assets do I have? As doing this on behalf of your institution, what assets do they provide, or what assets do I have to engage in this advocacy? And or what resources do I need to actually do this work? And then what might my next steps be, right? So thinking about, okay, so based on all of this reflection and all of this discussion, what could I now do, right? Thinking about that. And this is just sort of some guiding questions for advocacy action planning. These aren't like, this isn't the way necessarily to absolutely engage in advocacy, or these aren't the questions you have to answer before you engage, but they might be helpful in terms of thinking about how you can engage in advocacy, what is some ways to engage in advocacy, and how to strategize that. Next slide. All right, so we're going to do just one breakout room activity, and we're going to do it a little differently today. We're going to try and have folks self-select their rooms. So Priscilla and Christina have done a great job of creating a little bit of a different way of doing breakout rooms. So you're just going to self-select based on your level of training. Ideally, we don't want like 30 people in one room, and there's, I think, about 60 of you on this call. So, try and select rooms where there's like less than 12 people, but we're going to have you self-select your room. And then before you go in, I just want you to take a picture of the slide, because this is going to be the questions that I want you to just think about. What issues or concerns might benefit from your advocacy? And again, just thinking about that, and thinking about like, what does that conjure up for you? What advocacy steps or actions might you consider or take given sort of these issues or concerns you've raised? And what resources or support do you need to take your identified steps or actions? So, again, as an example, maybe I'm in graduate school and maybe I want to advocate to have more of us trained on, or have us receive formal training on the CFI. Okay, so if that's something you'd like to do, what might be your next steps in thinking about that, right? Maybe I want to advocate for, diversity, equity, inclusion, justice sort of seminar series that happens at our, graduate program once every month, right? A monthly luncheon, if you will. How would you go about doing that, right? Just thinking about what issue or concern is on your mind in terms of something that could benefit, again, your communities, your patients, your colleagues, what have you. What steps or actions might you consider taking? And then what resources or supports would you need to take your identified steps or actions? So again, we're gonna let folks self-select their breakout rooms, and we're gonna see how that goes. And then I will have you do that for like the next 10 minutes, and then we'll pretty much be at the end. We'll just be the only things left would be to wrap up at that point. So Priscilla, do you wanna lead them in their breakout room stuff?
Yes.
You can record, Priscilla. Perfect. So where do you begin? So you can just begin in terms of like, we talked about a lot of different things, but in this series, but really just thinking about, okay, how can I begin to center voices just in my own day-to-day? You can start to engage with your community, understand their experiences, identify their needs, start to develop partnerships or start to develop identify those who you want to build partnerships with and build trust with, and always centering communities. There's a saying, nothing about us without us. It's a quote. I can't figure out who the original author of that quote is. I've looked several times, but it's attributed to various sources. But it's that idea about nothing about us without us. So without communities, without their input, we really can't develop anything that's effective for them. Their input has to be central to that. And so just thinking that quote, it's a mantra that I try and keep in the back of my head when I'm working with any community, sort of remembering that they have to be centered. They have to be at the center of all of our efforts, that nothing should be developed or created or designed without their input. Next slide, please. Advocacy, you can advocate for processes and procedures or tools and strategies that can help promote equity, advocate for resources and support from faculty, from staff, and then advocate for changes in practices and processes. Next slide, please. And then as just an individual, question. If you see gaps, you see you're not reaching certain groups or certain populations, we're not taking into account certain groups or populations, question why that is, question where those gaps are, and question why those gaps exist. No one will make change without it being brought to their awareness. So even if you just bring it to someone's awareness, that's an important step in the right direction. Commit to doing these actions and work. Social justice, again, not just a goal, but also a process. And so really committing to steps in that process, and then engaging civically. So voting, local school boards, local elections, all really important. So as an individual, definitely do that. Sort of capturing this quote, I alone cannot change the world, but I can cast a stone across the waters to create many ripples. So everyone has a role in this work. Everyone has a role and an important role really to play in promoting social justice. So find, what your role is, find what you can do. And I would just say sort of commit to that as well. Next slide. Okay, in summary, basically everything on here, I won't go through it all. It's basically just there for reading. So next slide. And then at the end of the day, social justice requires individual actions like we talked about, and it requires systemic and transformative change. Next slide. And what's next? There's more to come. So I will hopefully be working with Priscilla and her team for additional training. We're hoping to do like a more advanced training or some additional trainings in this space moving forward. If you're interested, obviously you'll get some emails from the team because you're registered for the series. But in addition, if you're interested in anything, just definitely shoot me an email. I'll have your personal email, and then I can always forward you any upcoming trainings things as well. So feel free to email me with that regard. With that said, I'm going to move over to the GIPRA. Here we go. GIPRA evaluation. Like, again, this is really important for the work that NALBA does. So please feel free to fill out the GIPRA. I know we're sort of right at time. I just want to thank you all for your time. I know that this has been 2 weeks, 4 sessions over the course of 4 days. I know it's a lot of time. I know you could be spending your time doing lots of other things rather than listening to me talk. So I greatly appreciate your interest, your attendance, your participation. I may have not always done a perfect job. And if I haven't, please let me know. I'm happy to take feedback. But definitely, please feel free to reach out to me if you have any questions, concerns, if you're interested in future training, definitely let me know. Again, I want to thank you for your time. You attending is the first step can be a first step in this work too. It is a step in this work. So definitely, I appreciate all of your time. So thank you.
Thank you, Dr. Sampilo. Thank you, everyone. Please answer our evaluation. We appreciate your participation and we hope you have a lovely week. Thank you. Obrigada.
Thank you.